Hello, everyone. Thank you for joining. I am excited to introduce you to Dr. Kim Dennis and Dr. LaFata. It's going to be a great presentation today. Just for some housekeeping, if you are attending the seminar for CME or CE credit, you do need to attend the entire presentation to receive credit. We will send an email out after, giving you instructions on how to take the survey and complete everything you need to then claim your CME or CE. Very excited. We've done a lot of presentations for SunCloud, and Dr. Kim is amazing and brings on the best speakers. I rave about it everywhere I go. So we're in for a treat today, and Dr. Kim, I'll let you take over.
Hi, everyone. Thank you so much for coming. I'm Dr. Kim Dennis. I'm a adult psychiatrist and board certified as well in addiction medicine and an eating disorder specialist. And I'm the co-founder, CEO, and medical director at SunCloud Health. I'll tell you a little bit about who we are. We are based in the Chicagoland area. We treat complex co-occurring eating disorders, trauma, addiction, and primary mental health disorders. And we have two residential units for adults. One of those is specifically for patients with eating disorders and co-occurring addiction. And the other is a more generalized unit. We offer IOP, PHP, and outpatient as well for adults and adolescents in the Chicagoland area. We have interventional psychiatry as part of what we offer, including TMS and esketamine or Spravato. And we also are engaged in research and hoping to be able to add to the research base, translational research to help our patients and academics to be able to develop better treatments that help more patients. I am grateful today for SunCloud in putting these together and supporting these continuing education events where I get the benefit of being able to invite speakers like Dr. LaFata to participate. And I just want to thank Tammy, Robert, and Sal on my team for all of their footwork in putting this on today. And without further ado, I have the great delight in introducing you all to Dr. Erica LaFata. She is an assistant research professor at Drexel University Center for Weight, Eating, and Lifestyle Science, and she's a licensed clinical psychologist in the state of Pennsylvania. She earned her doctoral degree in clinical psychology from the University of Michigan. Her program of research applies a cutting-edge perspective to understanding overeating and obesity by examining, one, how ultra-processed foods may be reinforcing in a manner that directly drives overeating. Two, whether core mechanisms of addictive disorders, like withdrawal, might contribute to eating-related problems for vulnerable individuals. And three, how ultra-processed food addiction may be a novel, clinically useful presentation to inform individualized interventions. Dr. LaFata has investigated these empirical questions using a multi-method approach, including neuroimaging, scale development, food consumption paradigms, and self-report. And she has published over 40 academic papers and 5 book chapters on this topic. She is the recipient of a K-23 Career Development Award funded by the National Institutes of Health, investigating whether ultra-processed foods, high in added fats, refined carbohydrates, or both, are most associated with biobehavioral indicators of addictive-like reinforcement. In 2024, earlier this year, Dr. LaFata was honored as an Association of Psychological Science Rising Star. I am just thrilled to have you here today, Dr. LaFata, as a person who is both an addiction medicine person and an eating disorder specialist. It is not lost on me that this is a highly controversial topic, particularly among my eating disorder colleagues. And I'm just, again, delighted to be able to have conversations like these and to have academics of your caliber coming and sharing with us the most cutting edge research.
Thank you so very much for having me. I really appreciate the invitation, the very warm introduction, and I'm really looking forward to facilitating some discussion today. So I will go ahead and share my slides. Just take one moment to get set up here. All right. Is everyone able to see those okay? Maybe.
Yes, I can see him.
Okay, thank you. So during the presentation, just the way that Zoom works, everyone is minimized. So from my view, so if you do have a question, we'll leave 30 minutes at the end approximately for questions. If anything is going wrong with my slides or anything during the presentation, please just interrupt me so I can be aware of that as soon as possible. I believe that there may have been some slides related to SunCloud, or am I mistaken about that?
There
Yeah, for
may
some
have
reason,
there may
yeah,
have been, but those didn't show up. So I covered it in what I said.
Okay.
Yeah, and Tammy, who you hear speaking, will jump back on at the very, very end to let people know how to get their continuing education.
Okay.
You can use the chat or the Q&A feature on your Zoom as questions come up for you, and we'll address those in the Q&A section.
Okay, perfect. Thank you. Just wanted to make sure I didn't dive right in out of excitement without missing anything. So, really looking forward to this conversation. The title of my talk today is Ultra Processed Food Addiction Real? A Critical Perspective and Discussion of Health Inequities. Before we get started, I just want to acknowledge that I don't have any conflicts of interest for the presentation. My research program is fully funded by federal and state level grant mechanisms from the National Institutes of Health, as well as the Pennsylvania Department of Health through a pilot study program. So no industry related conflicts of interest, and that will come into play for why that's relevant early in my talk. So a couple goals for this presentation. The first is to present evidence for the addictive potentials of ultra-processed foods and the utility of ultra-processed food addiction as a novel clinical presentation. Second, I'll describe some systemic influences that contribute to the recognized health inequities in this presentation. And third, I'll discuss clinical implications that may follow if ultra-processed food addiction is recognized as a psychological diagnosis. So to dive into the evidence of the addictive potentials of ultra-processed foods, I just want to start by level setting about what are ultra-processed foods. So scientifically, these are best conceptualized by the NOVA food classification system, which is developed out of Brazil by Carlos Monteiro and colleagues. Ultra-processed foods reflect the group 4, the highest degree of processing for foods. These foods are industrial formulations that have been designed intentionally to be hyper palatable by combining artificially high amounts of rewarding ingredients. So things like oils, white flour, refined sugar, and salt. Importantly, these foods contain little, if any, whole food ingredients. So they're kind of unrecognizable with respect to their whole food forms. Some examples of these foods are pastries, frozen desserts, candy, white flour products, packaged snacks, fast foods, processed meats, sugary breakfast products, and sweetened beverages. So colloquially, we might be thinking of like quote unquote junk foods when we hear, in the public what these foods are. But scientifically, it's really important to distinguish what is it about these foods that make them so easily overconsumed. Importantly, no naturally occurring foods contain the combination of fat, refined carbohydrates, and salt. So there is something unique about this group of foods in the way that their ingredients are compiled and combined to be more rewarding. And also, there's a lot of additives that are specifically designed to enhance palatability. So things like texturizers, different colors that can get added to make foods more enticing. So there's just something fundamentally different about these foods. There's some interesting timelines that I like to point out when we think of how these foods kind of fit into this broader narrative of directly contributing to, overeating and associated concerns. So in the past 40 to 50 years, we all know that rates of overweight and obesity have increased. In combination with this, diet-related diseases have increased in prevalence. And notably, binge eating disorder has emerged as a more widely accepted clinical presentation, and prevalence rates have increased over this time as well. And the narrative we hear so often is, you're responsible, you have control over what you're eating and what you're doing. Balance what you eat and do is kind of this industry-driven model. But have people really become less responsible for their eating decisions in a way that has contributed to these changes over the past few decades? I'm going to be arguing that there is converging evidence that really implicates the rise of these ultra-processed foods in our environment as having a very causal role in overeating, obesity, and diet-related diseases. So where did these foods come from? Interestingly, I learned this probably like several years ago, and it's really been a mind-blowing piece of context for the research that I've been conducting. Um, Philip Morris, a big tobacco company, actually acquired Kraft and General Foods in the 1980s. This is right around the time that like cigarettes and tobacco products were being identified as addictive. Since the 1980s, there is empirical evidence that has demonstrated that ultra-processed foods have been disproportionately invented, marketed, and sold by these tobacco-owned food companies. Food companies that haven't been owned by the tobacco industry have historically made fewer of these foods, though it's kind of an even playing field now. But if we're thinking back to like what prompted this change 40 to 50 years ago, this is a really interesting piece of that puzzle. There's also a lot of internal tobacco industry documents that have come out of the University of California, San Francisco, that have exposed admissions of following the playbook of tobacco products in making ultra-processed foods. So the tobacco industry leaders essentially kind of translated their skill set to the food industry and used this when they were making ultra-processed foods. This includes overlapping ingredients and flavorings that have been added to tobacco products and certain ultra-processed foods. There's extensive research to understand the hedonic or reward-driven bliss point of these foods. They've been created to have similar pharmacokinetics, which is essentially the scientific word for like how these substances are absorbed by your body in a way that's more rewarding compared to naturally occurring reward. So addictive substances have an elevated dose of rewarding ingredients and a much more rapid rate of absorption for how quickly those ingredients hit your body. Importantly, a big theme of why this has happened is that there is this industry-driven prioritization of profits over public health. So these products have been intentionally created to be overconsumed, to be, repeat purchases to just fuel industry profits. So it raises this question, if there are similar properties of ultra-processed foods and similar players in who has created these foods relative to tobacco products, could these foods be addictive? And animal models strongly suggest yes. There's some really interesting potential for this work to be conducted in animals because it's very rare to find humans that have never had exposure to these foods, where you can really ask these questions of, do ultra-processed foods cause certain processes in the brain and in behavior? You need animals that have never had exposure to be able to rigorously test that. So interestingly, some recent studies in obesity-prone rats show that ultra-processed foods seem to directly alter neurotransmitter functioning and behavior. What this looks like is eating these foods upregulated, so increased NAC-AMPA receptor transmission. Basically, this is a reward-based receptor system in the brain that enhances cue-induced craving for drugs, and it seems to be also enhancing cue-induced craving for ultra-processed foods and driving more consumption. So there's a fundamental shift in the brain that ramps up craving and drives consumption. Importantly, this only occurs in the rats with the ultra-processed foods. So the naturally occurring equivalent in animal studies is nutritionally balanced chow. And it doesn't matter how you try to feed this chow, intermittent access, all of these ways that could potentially increase its rewarding potential. This doesn't happen, and it happens with ultra-processed foods. Also importantly, it preceded the development of obesity and addictive-like patterns of eating. So it seems to suggest that exposure to these foods in certain susceptible individuals, in this case, susceptible rats, seems to alter the brain in ways that precede the development of certain consequences or behavior. So these foods are fundamentally changing the brains of susceptible individuals. And I think that that's a really important piece of like the causal narrative that I think is quite compelling. In addition, we see evidence of tolerance, meaning that prolonged intake of ultra-processed foods has triggered the downregulation of dopamine, so another reward receptor, to trigger tolerance. We also see, major translations in behavioral responses. So again, in these more susceptible rats, prolonged ultra-processed food intake has triggered withdrawal, which manifests in rats as anxiety, preoccupation, and teeth chattering, an increased motivation to seek out ultra-processed foods, an excessive consumption or inability to stop eating them, and use despite consequences, which is a foot shock in these animal studies. In humans, we see a lot of translational evidence of these processes as well. So my doctoral mentor, Ashley Gerhardt at the University of Michigan, is a true expert in this. She was really foundational in kind of paving the way for the study of ultra-processed food addiction. And she recently wrote a paper that synthesized the evidence from human studies that applied the criteria that were used to call tobacco products addictive. So in court cases, when it was like compelling evidence that these products are addictive, there were 4 categories, and she recently collected evidence to see how our knowledge base of ultra-processed foods aligns with that criteria. So first, the ultra-processed foods are causing compulsive use in humans. We see this in a number of ways, that ultra-processed foods are consistently associated with binge intake, use despite physical or psychological consequences, which can look like eating these foods despite type 2 diabetes or despite having depression associated with eating behavior. The second criteria is that they're causing mood-altering effects in the brain. Clinically, we see this, pretty evidently that these foods temporarily increase positive affect or decrease negative affect. And they also engage addiction-like reward circuitry in the brain. These foods also reinforce behavior. So eating them increases cravings for ultra-processed foods and promotes more intake. Kind of becomes this vicious cycle of the more you eat, the more you crave, the more you eat. And obviously cravings, I think clinically this is the one that's easiest to identify and argue for, that these foods are strongly associated with cravings in ways that we just don't see with naturally occurring foods. So along that point, a key takeaway here when we're thinking about these properties is that it really is distinct to this class of foods that has been industrialized, created to be intentionally rewarding. And naturally occurring minimally processed foods like produce, whole grains, animal proteins don't meet any of these criteria in a way that causes, clinical levels of impairment or distress. You might have cravings for foods that fall within these categories, but those cravings aren't, so strong that we're overriding, potential consequences that come from eating these foods. We just don't have the same linkage with respect to the consequences of overeating these foods relative to ultra-processed foods. So I want to take a couple of moments to next talk about ultra-processed food addiction as this novel clinical presentation as it's been studied in the research. Importantly, this is not a clinical presentation currently. There's a line of research that really launched in 2009. So this is still in the nascent stages, but it's a very compelling and interesting research question building off of the evidence we know about what these foods are doing, to the reward system. So the way ultra-processed food addiction has been assessed in the research literature has primarily been with the Yale Food Addiction Scale. The current version is the YPAS 2.0, and it is a self-report measure, which of course has limitations. One of the strengths of the measure is that it assesses the 11 DSM-5 diagnostic criteria for substance use disorders as they apply to the problematic intake of ultra-processed foods. So as a refresher, I've included those here. You can see that, a number of them are particular behaviors like excessive consumption, not being able to stop. Other symptoms really tap into the consequences of being able to function in your personal and professional roles, as well as continuing to use these foods or addictive substances despite consequences. And then the two core physiological mechanisms of addiction, tolerance and withdrawal. So very similar to how a substance use disorder is diagnosed in the DSM-5, ultra-processed food addiction is quote unquote diagnosed, again, just a categorical measure of does someone present or not present with this, empirical presentation. It's two or more of these symptoms and an endorsement of either clinically significant impairment or distress. So just to underscore, this is just a research construct at this time. It is not a clinical presentation, but operationalizing it and trying to categorically point out who may or may not be exhibiting this presentation has really facilitated the line of research that I'll be talking more about. So when we're looking at those 11 DSM criteria, this is a large study of adults in the United States. There's a pretty strong rate of endorsement for experiencing these symptoms. Importantly, I'll draw your attention to the last line of this table. About 15.9% of individuals in this study reported clinically significant impairment or distress. And in this particular sample, 15% of people met criteria, again, based on that questionnaire for ultra-processed food addiction. And that rate is pretty similar to what we see for alcohol and tobacco use disorder. So other publicly available, albeit with restrictions, but legal addictive substances, it seems like the prevalence rate is pretty on par. We know that you don't have to have an addiction presentation in order to experience symptoms of addiction. So I will only implicate myself, but if you are someone who drinks alcohol and you've had a hangover, that is technically a symptom of withdrawal, and I have experienced that. So we can kind of think about these symptoms are unique to addictive substances, but they're not unique to people who have addictive presentations. You can experience these consequences just by having a bit too much, but you wouldn't experience withdrawal in the same way from naturally occurring foods. So I want to take a few minutes to address some common misconceptions before we proceed to kind of distinguishing this presentation and talking about its clinical implications. The common one I get is we need to eat to survive, so food can't be addictive. This is maybe a silly sentence and analog here, but if we need to drink to survive, does this mean that alcohol can't be addictive? It really is this particular class of foods that has been created that does not resemble the naturally occurring foods that we've evolved to need to survive. And in a similar way, alcohol is not necessary for survival. Neither are ultra-processed foods. We didn't have them for most of history. Importantly, the foods that we do need for survival don't trigger these responses. So I'm not talking about those foods at all when I'm referencing, the rewarding potential, the consequences that are associated with that. Those foods are not implicated. There's a lot of strong empirical evidence for that. Another one is I can make cookies at home. Are those still addictive? Well, yes. Homemade wine would still be an addictive substance. However, and most importantly, the industrialization of these ultra-processed foods has exponentially increased access, affordability, and convenience. And that's really where we see those time courses track. I always think of my grandma's, homemade chocolate chip cookies that she makes and has always made. And what's really changed about our food system is not my grandma's cooking. It's really what the industrialized food environment has evolved to. So when we're thinking about are those cookies addictive? Well, potentially they're more addictive than the broccoli she made for dinner. However, there are some really important key systemic influences here. And finally, a misconception I get frequently is that people report overeating foods besides ultra-processed foods. And this is absolutely to be expected. The overconsumption of sugary drinks, for instance, didn't reduce the validity of alcohol use disorder. In a similar manner, if someone is reporting overeating foods besides ultra-processed foods, that may be another presentation of problematic overeating, but it wouldn't be ultra-processed food addiction, which is the presentation that really requires the specificity of addictive responses to this class of foods. This is not to invalidate those presentations where people are struggling with other types of foods. Importantly, there's an array of existing eating disorders that speak to those phenotypes a lot better than ultra-processed food addiction does. This presentation is very specific to that class of foods in the same way that alcohol use disorder is very specific to alcohol. So another important domain that I'm going to spend a decent amount of time talking about because it's currently a key conversation in the research is ultra-processed food addiction binge eating disorder. So despite a high number of individuals with binge eating disorder meeting criteria for food addiction, ultra-processed food addiction, it's about half of individuals with binge eating disorder seem to meet criteria based on that questionnaire. Most people with ultra-processed food addiction do not have binge eating disorder. So the lifetime prevalence of binge eating disorder is about 2.8% based on a recent estimate. And similarly, the prevalence of ultra-processed food addiction in a representative sample is about 15 to 20%. So this is the way I think about it. There is substantial overlap when we're looking at populations of binge eating disorder. But when we're looking at populations with ultra-processed food addiction, there seems to be a lot of people who are really not captured by existing presentations of eating disorders that are currently just not receiving treatment and not recognized as needing such treatment. So this does seem to be an overlapping but also distinct presentation. I'll talk a little bit about each of these domains. But it's important to understand, like, where does this overlap come from? There's a lot of shared phenotypic features, clinical characteristics, and theoretical perspectives. There's obviously also a lot that's distinct. So we're going to dive into that because I feel like it's something that I'm having a lot of conversations about right now. So looking at these characteristics, again, these are the 11 diagnostic criteria for substance use disorders that are also applied to ultra-processed food addiction, same criteria. So some of these are just characteristic of kind of normative overeating. We all have food cravings. I've had a craving for a glass of wine. I will only implicate myself here. And also Doritos, right? Like these are normative experiences. Consuming more than planned. Absolutely. We're coming up on Thanksgiving. I think that's the perfect example that I use year round, and it's more relevant this month than ever. Sometimes normative experiences of overeating are also characterized by feeling a little bit unable to cut down or stop. So you might eat more than you planned. You might feel like it was harder to stop eating than you thought it would be. But in normative experiences of overeating, these consequences, physically hazardous situation, and addiction-like mechanisms are not present. When we're looking at binge eating disorder, these symptoms are extended a bit. So it's one of the diagnostic features is being unable to cut down or stop. This is essentially like clinical impairment or distress. There's a bunch of other indicators of clinical impairment that can sometimes be present. Some features that are not discussed in binge eating disorder is the use in physically hazardous situations specifically, and then these physiological mechanisms of addiction like tolerance and withdrawal, definitely not characteristic of how we think about binge eating disorder. So hopefully this paints a picture of like, yeah, there is a decent amount of overlap that can present with addiction criteria, but also some really distinct features, and we'll talk about those as well. So withdrawal and tolerance are key distinct features of addiction that are really not characterized in binge eating disorder. There's really nothing about the foods themselves that would be thought to cause withdrawal or tolerance. If anything, it's the opposite. And we'll speak about that when we're talking about the theory. The pattern of intake also looks different in binge eating disorder and food addiction. So for binge eating disorder, we know there's these discrete binge episodes, But an addictive-like presentation could look like binge consumption, but it could also look like grazing throughout the day. So I'm thinking of someone who, may have binge consumption of alcohol when they're at a social event, or drinking alone after a stressful day. That could look like binge consumption. But another type of addiction presentation could be the individual who wakes up and has a drink first thing in the morning and continues to drink, consistently throughout the day. Both would be presentations of addiction. Binge eating is very specific to these discrete binge episodes. The quantity of intake is also distinct here. So in binge eating disorder, for a clinical diagnosis of binge eating disorder, we know there need to be objective binge episodes that it do involve an objectively large amount of food. Again, the type of food's not specified. In an addiction presentation across all substance use disorders, there's actually not a threshold for how much you have to drink, consume, or use to meet criteria for the addiction. It's really more characterized by the behavioral features, those 11 symptoms that I was mentioning. And most importantly, if those features are also causing clinical impairment or distress. And then another very key distinction is the specificity of the foods. So for binge eating disorder, the diagnosis does not depend on eating certain foods, though there has been one study that I'm just very stuck on right now that shows up to 100% of binge foods are ultra-processed foods. So there does seem to be this overlap in the types of foods that are consumed more likely, but there's nothing diagnostically that says it has to be those foods. So people who are struggling with other foods besides this class of ultra-processed foods I've been talking about, they might be a better candidate for assessment for binge eating disorder. For ultra-processed food addiction, I think I've made this clear enough. It's all relevant to those specifically that class of foods. So one of these core mechanisms that I've taken a lot of interest in empirically is looking at withdrawal. And does withdrawal present when we remove ultra-processed foods from the diet? To me, this is a really strong proof of construct of if this is real and if food addiction does exist, we should be able to see some patterns of withdrawal. So on my way out the door in graduate school, I developed the highly processed food withdrawal scale. And highly processed and ultra processed are synonyms. We've kind of evolved once Nova came out. This is dating me for when Nova came out relative to when I was in grad school. But highly processed was a little more popular then. Now we actually have an operationalized framework, and ultra processed is the categorization. Importantly, when I asked people about the last time they cut down on ultra processed foods, what happened? I adapted this measure based on the Wisconsin smoking scale, withdrawal scale. So it was looking at similar physical, like headaches, and psychological, like irritability symptoms when someone is cutting down on ultra processed foods as when someone cuts down on nicotine products. In addition to showing those similar symptoms, we did find that there was a parallel time course. So in kind of pulling out, like if you felt down or irritable or tired or had cravings, when was that most intense relative to when you cut down on these foods? And interestingly, in this days 2 to 5, there seems to be a real peak among individuals across these symptoms that then takes a downward slide, there forward. And that time course strongly parallels what we see for substance use disorders as well. Days 3 to 5, 2 to 5 are very strong for withdrawal. Interestingly, having more symptoms of withdrawal explained 11.2% of the variance in self-reported quote unquote dieting success, which was defined as were you actually able to remove these foods from your diet as planned. Which 11.2%, it was a very highly statistically significant. And then this was also replicated in use. So it's important to think about how this might be affecting younger individuals in a way that really isn't precedented in other addictions, is how early these foods are introduced in our food environment. So kind of getting back to our distinctions with binge eating disorder and ultra-processed food addiction, the theoretical perspectives are really important as well. In binge eating disorder, there's really no role of a substance, right? We wouldn't expect there to be. In an addiction framework, this is really key. So like addictive substances, ultra-processed foods are thought to directly cause and maintain an addictive pattern of intake. Ultra-processed food would not, addiction would not exist without ultra-processed foods. Alcohol use disorder would not exist without alcohol. So that class of foods is essential to driving this presentation. And that's not shared at all by binge eating disorder. Dietary restraint is a very, very important one. In binge eating disorder, the traditional theory recognizes that restricting dietary intake or certain foods is a risk factor or precursor to binge eating disorder. And there's some empirical evidence about how strong that linkage is. But typically, dietary restraint is thought of as a risk to binge eating. Dietary restraint has not been associated with ultra-processed food addiction, and it doesn't seem to be a risk factor for the development of ultra-processed food addiction in the same way that we see it as a risk factor for binge eating disorder. This was demonstrated in a 2-year prospective trial that dietary restraint did not precede the development of ultra-processed food addiction. I like to think of dietary restraint in the context of food addiction as a consequence of having this addictive like propensity or draw towards these foods. So if you're experiencing an addiction, it's kind of typical if we think about alcohol again, if you are, developing an addiction to alcohol or have one, you might try to cut down on alcohol to try to break that addiction cycle to kind of protect yourself from what that substance can trigger in your brain and in your behavior. So it's a consequence or an effort to like improve and or break out of that addiction cycle. In a similar way, it seems like efforts to cut down on ultra-processed foods in the context of ultra-processed food addiction seem to be really motivated by this desire to limit a person's exposure to reinforcing properties of ultra-processed foods. And again, this was demonstrated in that 2-year prospective trial that I'm referencing, as well as in qualitative studies of individuals who present with this presentation. Finally, shape and weight concerns, in a similar way, have been acknowledged as just a risk factor for the development or maintenance of binge eating. And in ultra-processed food addiction, it's also conceptualized as a consequence of prolonged ultra-processed food intake, similar to how someone who smokes might have an increased concern about lung cancer over time. Someone with ultra-processed food addiction might be concerned about how these ultra-processed foods will impact, perhaps their shape and weight, perhaps their health, perhaps their mental health. There's a lot of different domains that we would expect there to be some sort of consequence of prolonged intake. So importantly, when these things co-occur, we get clinically meaningful information. So it's not either or, it can be both. So there seems to be some clinical utility of assessing ultra-processed food addiction among individuals who have binge eating disorder. Again, there's about a 50% overlap, so it's pretty significant. Among persons who have binge eating disorder and ultra-processed food addiction, compared to only having binge eating disorder, have a more severe presentation. So individuals with both have a greater frequency of objective binge eating episodes, a higher intensity of food cravings, more preoccupation with food and eating decisions, more time spent dieting, poor emotion regulation, increased negative affect, more comorbid mood disorders like depression and anxiety, and lower self-esteem. So clinically, it seems like ultra-processed food addiction is adding a lens and kind of collaborating with what we know about binge eating disorder to tell us more about, more risk factors, more intense eating pathology, and potentially it might suggest that there need to be additional treatments added on for these individuals to try to understand how we can improve outcomes with this severe presentation. If we're looking at ultra-processed food addiction in the absence of binge eating disorder, and importantly, in the absence of any existing eating disorder, these individuals have clinically significant impairment and distress related to their intake of ultra-processed foods. These individuals seem to be eating a lot more of these foods, so up to 11 times higher intake of ultra-processed foods. This is also linked to an increased incidence of obesity and type 2 diabetes, greater experiences of weight cycling, so gaining and losing weight time and time again, A study I conducted during the first year of COVID showed that there was 6 times greater weight gain during that year-long period. So individuals with ultra-processed food addiction gained about 12.5 pounds compared to 2 pounds for those without. And there's also an array of comorbidities. So increased depression, anxiety, post-traumatic stress disorder, adverse childhood experiences, non-suicidal self-injury, and higher suicidality risk. All of these things also culminate in a lower quality of life. So this is a clinical presentation to be considering seriously when it comes to how are we improving outcomes for people who are struggling with eating-related concerns. And I hope to have underscored that this really isn't at odds with existing eating disorders in any way. There could be some additive potential to considering them together or assessing for this together, but it's all in the service of helping individuals who are struggling with their eating. And this is just another lens to add to that picture. So other, commonly occurring psychological conditions like depression, anxiety, the presence of one doesn't negate the clinical significance of the other. And from my perspective, this really is an additive potential to help and identify more people. So we're going to talk next about some health disparities that are associated with ultra-processed food addiction that really further drive why, I really care about advancing the science in this area. So the prevalence of ultra-processed food addiction, I've alluded to, but there's been 2 systematic reviews and meta-analyses of 281 studies that represent 36 countries around the world that have estimated the prevalence of ultra-processed food addiction. So a really rigorous amount of research has been done. In non-clinical samples, which the way that they define it excludes individuals who have obesity. So among individuals of normal and overweight, 14% of adults seem to meet criteria using the Yale Food Addiction Scale for ultra-processed food addiction, which, as I've noted, is similar to alcohol and tobacco use disorders. This is also present in 12% of use, which I think is, particularly concerning and unprecedented with comparisons to other addictive disorders. When we think about clinical samples among persons with obesity, 19 to 25% seem to meet criteria for ultra-processed food addiction. And this is really to, further underscore that this is not synonymous with body weight. This is something that's been identified across presentations of individuals across the body weight spectrum. And so when we're thinking about like the earliest research in this area that's showing, individuals with obesity have parallels with addiction circuitry, like those parallels are not fair. Obesity is a proxy for an array of things that could have nothing to do with eating behavior. So I really have appreciated the reliance on a clinical presentation and endorsement of actual problems and consequences of eating behavior, as opposed to relying on body weight as a proxy for that eating behavior. As I've noted, about half of individuals with binge type eating disorders have experienced or have reported this presentation as well. There's some really interesting health disparities that emerge when we look at nationally representative samples of the United States. Rates of ultra-processed food addiction by racial and ethnic identification were pretty striking. So this is a study I conducted maybe 4 years ago at this point. The prevalence among individuals who identified as white was around 12%. And we see pretty substantial increases among persons of color and individuals who identify as Hispanic had about a third of them endorsed ultra-processed food addiction. So this is a pretty striking discrepancy. In this study as well, those who reported having a lower household income and exhibited symptoms of ultra-processed food addiction were more likely to have a higher body mass index, suggesting that among those who might have less access to a wide array of foods in their food environment and who had, a presentation that was associated with addiction responses to these foods were more likely to have these negative consequences or develop obesity. And really interestingly, household food insecurity has been reported to increase the risk of ultra-processed food addiction by 21 to 56%. So really suggesting this systemic role of access to certain foods and the prevalence of these ultra-processed foods in vulnerable communities. So how has this happened? Bringing it back to the industry lens and just trying to understand, is there anything that explains these discrepancies? It's important to recognize that big food companies have targeted persons of color when they've marketed ultra-processed foods. There was a minority marketing plan, that was the name of the plan, initiated when Philip Morris, the tobacco company, bought Kraft and General Foods in the 1980s. Because of this, strategies marketing tobacco to persons of color were applied to ultra-processed foods starting in the 1980s. So again, based on this minority marketing plan, which came from the tobacco company. This plan disproportionately targeted marketing in media outlets and locations that were frequented by Black and Hispanic individuals. It included corporate-sponsored community events in these communities. It associated specific brands with underrepresented groups. So a beverage, an ultra-processed beverage called Tang was marketed primarily to Hispanic families. And it included Black and Latinx celebrities in fast food campaigns. So very targeted initiatives to try to market these foods that were, very affordable, relatively speaking, really accessible, to try to, potentially exploit certain populations to make this part of their cultural identity. This made me really angry, and just thinking about the intentionality that went behind this. And this is something that is exposed in industry documents. It's not, a subjective initiative. There's evidence for this that's been specifically spelled out. And there's, many more examples beyond what I've listed here. So when we're thinking about systemic influences on ultra-processed food intake, when we kind of boil this down, these foods are cheap, they're calorie dense, and they're an understandable common choice for individuals who have lower household incomes or may be experiencing food insecurity. So it comes back to this point of, we do need to eat to survive, but we don't have to eat ultra-processed foods. The abundance of these foods in our food supply really influences food choices and is really leading to these addictive responses in children and adults. It goes beyond willpower and personal responsibility. I think it would be really awful to be applying that lens when we're thinking of health disparities. Is a group of individuals less responsible because of the systemic influences that they face when, ultimately it's up to you to balance what you eat and do. I find that infuriating, and just thinking about minimizing the systemic influences that are present there and the industry-led initiatives as well. We know that psychoeducation campaigns have been minimally effective for increasing public policy change. And of course, these foods are highly reinforcing. So this further motivates intake among people who might be experiencing chronic stress, like a family who's experiencing food insecurity. In addition to all of this, the social acceptability of these foods is unprecedented compared to other addictive substances. If you can imagine for a sec that there were as many cues for alcohol as there were for ultra-processed foods. When I was giving talks in person, pre-COVID, primarily, there was typically a buffet of bagels and pastries and things in the back of the room where I was speaking. And I always, wondered, there would never be a mimosa bar back there, right? We are consistently faced with these experiences to decide to choose ultra-processed foods or another option, and often there isn't another option. So just think about the role that the food environment has, that plays in all of this. And I think it's a really important lens when we're contrasting that with this willpower narrative that is, often pushed by mainstream media. So the last kind of segment of this talk is to think about clinical implications of ultra-processed food addiction. So there's been some data on treatment outcomes. In cognitive behavioral therapy for binge eating disorder, individuals who have ultra-processed food addiction and binge eating disorder, compared to those with just binge eating disorder, have greater treatment dropout. They have a lower decrease in binge eating frequency. They have a lower likelihood of achieving full remission. And ultra-processed food addiction seems to mediate the relationship between binge eating severity and treatment outcome. So it seems to be a meaningful predictor in treatment engagement and treatment outcomes. In behavioral weight loss programs, one of the most compelling trials to date was a 12-month randomized control trial of a little over 600 individuals that found ultra-processed food addiction was the strongest psychosocial predictor of increased dropout and decreased weight loss. While this laundry list might feel a little long to read, I want to say it because each of these have been associated independently with poorer outcomes in weight loss trials. But ultra-processed food addiction was a stronger predictor than body dissatisfaction, emotional eating, dietary restraint, perceived stress, quality of life, depression, sleep quality, self-efficacy, and social support. There were 41 total predictors in this model, and ultra-processed food addiction was the strongest predictor of these outcomes. To me, that just underscores that this is a research question that is worth studying. It doesn't, I'm not drawing the conclusion that this is a, presentation, not jumping through steps, but we need more research on this. It seems important. In comparing treatment components, I found this really interesting to look at the commonalities of how do we treat binge eating disorder and how do we treat substance use disorders. There is a lot that is similar. Both treatments are identifying triggers that precede problematic consumption. There's ways to cope with, small lapses and prevent relapses. There is psychoeducation on healthy behavior change, identifying automatic negative thoughts, sometimes exposure and response prevention. It's more so in substance use disorders, but it is present in some treatments for binge eating to reduce restriction. Developing, practicing, and substituting alternate activities, enhancing social support, and pharmacology, all considered in both treatments. The unique aspects for binge eating disorder is that there is this primary goal of remission from binge eating episodes. There's a caution about limiting binge foods, emphasizing moderation to prevent dietary restraint. And there's really no recognition or limited recognition of the role of the food itself. The, common mantra from Fairbairn's CBT was no good foods, no bad foods. In substance use disorders, the primary goal can be abstinence or it can be remission from high-risk patterns of use. The substance is recognized as the primary cause of compulsive use and related consequences. So again, no alcohol use disorder if alcohol isn't existing. And a key treatment component is managing withdrawal symptoms. So trying to help individuals recognize that being, off of a particular substance is what is causing this acute discomfort. They have to get through that acute discomfort with skills that are taught in treatment in order to, have an easier time, after that acute withdrawal period in managing their cravings and other things that are more lifelong. So what are the mismatches in these treatment approaches? For individuals who have substance use disorders, we know for those addictive substances, consuming the substance in moderation can actually exacerbate addiction. So if someone has, we'll just say if someone's smoking, to not use alcohol for another example, a smoker who has the advice to smoke in moderation, we've never heard that really for addiction, and there's a reason for that. So those intermittent access to addictive substances can really exacerbate the likelihood of relapse and the addiction presentation. Importantly, this is only for people who have substance use disorders. So I am not a smoker. I could have a cigarette today and one in 3 days and nothing would really happen to me. But for someone who's struggling with an addiction response to tobacco products, that would potentially be a trigger for returning to their addiction. In addition, abstinence or remission from high-risk use really is this prerequisite to successful engagement in all other behavioral strategies. So it's thought that if you are withdrawing from cigarettes and you're in that acute withdrawal stage, the focus is getting through that acute withdrawal stage before you can be introducing, alternate reinforcing activities or other components of lifelong relapse prevention and management. Oops. And acute and sustained withdrawal are really associated with treatment dropout and relapse. So they really are central treatment targets from an addiction standpoint. Obviously, not something that's discussed for binge eating disorder because it's a core addiction mechanism. So I want to kind of close with this kind of thought experiment of pretend you are someone who is experiencing ultra processed food addiction, as I've described it, and binge eating disorder, and you're in treatment for binge eating. How might you feel if you're told that eating ultra processed foods in moderation would help you feel less deprived and reduce your chances of binge eating? But when you try this, you struggle to eat ultra processed foods in moderation because for you, ultra processed foods are causing addictive like changes in your brain and behavioral responses. So for you specifically, trying to eat these foods in moderation is actually causing more binge eating episodes. It's like trying to have one cigarette a day. It's really causing, more turmoil and more likelihood that you're going to have, additional eating experiences with these foods. How would you feel if you were advised to limit your exposure to ultra processed foods and triggers for binge eating? Sound advice, but everyone seems to be eating these ultra processed foods around you all the time. And there's something about your brain that feels especially enticed by these opportunities to eat ultra processed foods. And how would you feel if you didn't know the extent to which these foods played a substantial and direct role in why you're binge eating? Again, it's not really acknowledged that these foods are part of the problem in traditional binge eating frameworks that emphasize that no good foods, no bad foods type of approach. Most importantly, this is only for individuals who have this addiction presentation. I am not trying to challenge in any way the very strong evidence base of treatments for binge eating disorder that work for individuals. But for those who aren't responding to those existing treatments, might this be a lens that could explain what else could be going on and what else warrants treatment intervention? For those people, they might be thinking, what's wrong with me? Why can't I control myself? I know what I need to do, but I can't do it. I don't have any willpower. And there is a greater impact for ultra processed food addiction, given that there are very real and understandable financial and convenience reasons to choose ultra processed foods. In behavioral weight loss interventions as well, being in a physiological calorie deficit likely makes it harder or nearly impossible to improve addictive-like responses to ultra-processed foods. So when we're thinking about like common ground on like dietary restraint, being in a calorie deficit is definitely not a way to improve, a relationship or addictive responses with ultra-processed foods. But a eucaloric, like keeping calories the same, replacing those foods with minimally processed whole foods is more what I'm thinking for from an intervention standpoint. So there has been a bit of data on ultra-processed food addiction treatments, very few studies at this point because it's so hard to develop and rigorously test interventions for a novel clinical presentation that has not yet been recognized. Those are very expensive trials. So acknowledging that this could be a clinical presentation or a condition for further study in the DSM, which is something that Ashley Gerhardt and I are working on right now, would really facilitate funding. But the data that exists right now, there's 8 trials that have looked at if existing weight loss or binge eating disorder interventions have yielded improvements in ultra-processed food addiction. Medications seem to be most effective. Interestingly, naltrexone, bupropion, or Contrave is a medication that is derived from medications used to treat addictive disorders, and that seems to be highly efficacious for reducing addictive-like eating. Mixed efficacy has been bariatric surgery, and lower efficacy has been behavioral interventions, except one trial that has provided meal replacements that was actually pretty effective at reducing food addiction. To me, that's like take the food environment away, food addiction improves. It's kind of interesting distinction there. There's also been 3 studies that have demonstrated efficacy for low carbohydrate or ketogenic diets for improving ultra-processed food addiction. These diets lasted for 1 to 7 months, and there was also substantial weight loss and reductions in binge eating that were sustained for up to 17 months. I would say I like personally have concerns about the sustainability of a low carbohydrate or ketogenic diet in this food environment. However, it is compelling early evidence that I think also just deserves more of empirical study and understanding how this could be implemented. So some of the substance use disorder treatments to evaluate, I think pharmacology is a really promising agent. We know that in addictive disorders, pharmacology is really essential for interrupting that neurobiology that maintains addictive use. So for ultra-processed foods, reducing that reward responsiveness to these foods could be something that is extremely beneficial for being able to follow through with some of the behavioral recommendations, like limiting high risk situations for ultra processed food intake. This seems to be the least controversial add-on to existing interventions, as opposed to what I'll talk about next, more like abstinence-based or harm reduction approaches. There is pretty strong preliminary evidence with the GLP-1s that I feel are a big topic right now empirically, is understanding the transdiagnostic role that those medications could play. Another treatment that could be evaluated is an abstinence-based approach to ultra-processed foods. I'm not particularly keen on this one myself because it feels really unattainable and in some ways unnecessary in the current food environment. There is such a wide variety of ultra-processed foods, some including really adaptive foods like protein shakes or plant-based protein replacements. So that category is not perfect, but most of those foods are in line with what individuals have reported to be most addictive for those who experience this presentation. But there's more nuance to this class of foods compared to alcoholic beverages, for instance. So it seems that abstinence could be less attainable and probably unnecessary. Harm reduction is really what I'm most excited about for behavioral interventions. It's something that has been really strongly evidence-based in alcohol use disorder. So it individualizes risk factors like variations of the substance, different moods and situations. And the goal is to avoid high-risk triggers, but permit low-risk use. So an example of this might be avoiding hard liquor completely and avoiding any alcohol of any kind when someone is alone or stressed. So those would be avoiding the high risk situations. But if someone is saying that having a glass of wine at dinner with friends is a way to enjoy alcohol in a low risk context that is not related to triggering like lapses or relapses, that could be a way to integrate a low risk version of consumption. So because of the nuance of ultra processed foods and because of all the different individualized triggers that may be associated with it, this nuanced individualized approach to treatment seems to be really promising and interesting from a behavioral standpoint. So one of my final slides is just looking at clinical opportunities beside binge eating disorder. What we know is that most people with ultra processed food addiction are not identified as needing treatment currently. And recognizing this as a diagnosis, again, sometime in the future, has the potential to extend the scope of treatment to underserved populations, which include use. Again, 12% of use seem to meet criteria on the Yale Food Addiction Scale. There's really no sex differences in the prevalence of addictive-like consumption of these ultra-processed foods in men and women. So it's interesting to understand how males who might be struggling with, problematic overeating of these foods, maybe they're exhibiting this addictive potential, and that lens could be helpful for validating their experiences and providing them with treatment. As I mentioned, there's a disproportionate prevalence among persons of color and among individuals experiencing food insecurity. Obviously, from a systemic level, this is something that deserves a lot of urgent attention to understand, what's going on and how that can be addressed. We also know that there is a greater risk for an array of physical and psychiatric conditions among those with ultra-processed food addiction. So that could be a screening tool to identify individuals who might have a more complex presentation. And one thing I'm, really care deeply about and have emphasized several times is that this presentation could decrease the stigmatizing personal responsibility attribution for overeating, for obesity, for, different presentations of overeating. And when we're thinking about how this gets destigmatized, it's by really shifting some of that responsibility onto the industry that made these foods that people are really struggling with, and just looking at the time course of how this evolved and when this happened. So I really care deeply about that potential for having this be a validating explanation for individuals to understand, why they're not able to follow through with their plans. Um, it ultimately is true, of course, that people have ultimate control over what they eat. But I hope that this presentation has helped underscore that there are significant environmental influences like food advertisements and the availability of ultra processed foods that are swaying eating decisions more than is acknowledged. So responsibility really does need to fall on the industry, especially when we're thinking about health inequities and how that narrative of personal responsibility must be particularly stigmatizing for perpetuating these health inequities as well. So I will pause and open up the rest of our time. 25 minutes, not bad for presentation or for questions. My email is here as well. I'm happy to talk further about anything that may be of interest, but I will pause for one moment and then stop sharing my screen so I can take the questions.
Amazing. Thank you so much, Dr. LaFata, for just such a rich presentation and wonderful presentation. I invite each of you participants here today to, you could raise your hand or put in the chat or the Q&A box questions that have come up. I have several myself, so I could get us started, and there's also one already in the Q&A box. Where to start? I have about five. Um,
Do you want
so
me to
uh,
do you want me to start with yours, or do you want me to address the one that's in the
why
Q&A?
don't we address the one that's in the Q&A right now?
Sure. Okay. I'll do the one from Kaylee Billings, and then we can pause and take yours and get back to mine.
Yeah.
So the question from Kaylee is, can you speak more about what withdrawal symptoms might look like for ultra-processed food addiction? Do they look similar to other addiction withdrawal symptoms like alcohol, so including things like craving, physical symptoms, mood instability? So yes, there are parallels. So the scale that I developed is based on the Wisconsin smoking withdrawal scale. And that particular scale is, obviously specific to tobacco products. The reason I focused on tobacco is because there seem to be the most parallels between the scope of psychological withdrawal symptoms relative to fewer physical withdrawal symptoms. Tobacco withdrawal is very psychological in nature, whereas, something like grand mal seizures that can happen in severe alcohol withdrawal, we would not expect that to happen with ultra processed food withdrawal. So basing it more on the psychological indicators of tobacco seemed to make sense, theoretically. So there was a lot of parallels with irritability, with anxiety, sleep disruption. There were also some physical symptoms that we see with tobacco that overlapped, like hot flashes, headaches, but more minimal compared to the vast, majority of psychological withdrawal as well. So I hope that helps answer.
Awesome. Yeah. Might as well answer the second one
Yeah,
in
sure.
the,
For medications, I would say like the earliest evidence has looked at naltrexone bupropion, which is Contrave. That's a medication that does come more from like the addiction literature, interestingly. Not Contrave itself, but naltrexone and bupropion like separately have been used to treat like decreasing the reward potential from addictive substances. The promising direction for future research, I think there's been one or two randomized clinical trials looking at GLP-1. So the group of medication like Ozempic is the most popular, but tirzepatide or Zepbound is one that seems to be particularly promising, not only for weight loss, but for reducing that rewarding potential of foods in individuals with ultra processed food addiction. So I'm really interested to see that line of research. I'm a PhD doctor, not an MD doctor, so it's not one I'll really be able to perpetuate much myself, but I'm following closely and thinking about it clinically.
yeah. And I mean, there are a couple of studies now looking at the GLP meds and showing promising results for alcohol use disorder. So conceptualizing this as a substance use disorder or addictive disorder as distinct from an eating disorder, there may be overlaps, as you said, with Contrave. Naltrexone is a mainstay, Vivitrol for addiction treatment.
Yeah, thanks.
Okay, and
Mm.
yeah. And then Anne Wetley has asked if it is potentially unnecessary to abstain from ultra-processed foods completely in treating the addiction. What approach towards ultra-processed food can you advise clients to take?
Yeah, this is where I'm really come back to harm reduction as that nuanced, individualized approach. Clinically, from the individuals that I've worked with, I've probably had like 6 years of experience in working with individuals with disordered eating. And among those who are endorsing this addictive potential, it seems like there are really important, nuanced conversation of which ultra-processed foods are you struggling with? Is it certain groups of these foods? Is it individual foods? Are there any of these foods you can eat without problem, anytime, anywhere? And then looking at mood and environmental triggers. So being stressed is, obviously something we understand. Emotional eating is a super common trigger. Being in certain social situations where ultra processed foods are richly integrated into that celebration or the social ritual, those could be higher risk situations. So nuancing those to understand which foods actually need to be abstained from in a really nuanced way of specific foods or a small group of foods and certain environmental and mood triggers. And there also could be then other settings where these foods are very low risk to be consumed in a problematic way that are continue to be permitted. I hope that helps clarify a bit too.
Yeah, I mean, I think this is the question that always comes up clinically here at SunCloud, and we very distinct from all of my colleagues in the eating disorder world. It's like highly stigmatized to even talk about this, let alone say that you're a treatment center that treats it. So I know there are eating disorder professionals who just will not refer to SunCloud because we take a nuanced approach. And for people who do have an eating disorder and this phenotype that they experience as an addiction and that looks like ultra processed food addiction, I'm a big believer in honoring patients' voice and choice because they know, and we can help them discern between, well, what's a fear food, right, that you're trying to avoid for all sorts of cognitive distortion reasons versus what is a substance that's causing this physiologic brain response that separates you from the capacity to eat in ways that align with your own overall health goals, right? So sometimes that looks like, not like I think you said in the presentation, like it's virtually impossible in our current food environment to abstain from all ultra processed foods. And we know that different ultra processed foods have different health impacts, right? Not all ultra processed foods are created equally. Um, so patients, I think, will let us know. Patients let us know. Anyways, I can speak from my experience treating it. These are the foods that I just can't seem to control at all ever, and you mentioned too that context is important, and what types of settings and with what sorts of support. It might be a different experience sitting at a table with close friends in a group sort of fashion versus alone at home or in a drive-through somewhere, right?
Yeah, and I think that speaks very well to the anonymous question we received of giving examples of behaviors someone might do to reduce harm with ultra processed foods. It's thinking about those contexts where eating those foods or some of those foods is least likely to lead to overconsumption in a way that would cause distress. So, if sharing a ultra processed dessert somewhere is going to decrease the likelihood that you're going to want more, like that might be a context where it's easier to split something in public when you're, in a good neutral mood versus eating
Right.
something alone in your basement when you're stressed and it's been a horrible day. So that's the type of kind of behavioral harm reduction approach that I take. I don't know if there's anything else you want to add to that question.
No, I mean, those are exactly the kinds of conversations we have. One of the tools that we use often in the eating disorder world is, okay, let's make a red, yellow, green food list. For people with restrictive eating disorders, what are foods that you say you will never eat because X, Y, or Z cognitive distortion. You don't want to gain weight. It's going to cause, all the eating disorder, classic eating disorder distortions. What are the foods that maybe you can eat, and what are your safe foods? And the parallel for somebody with food addiction would be like, what are the foods that always cause you problem or that you feel are most problematic? What are the foods that sometimes trigger you and sometimes don't? And what are the foods that, like the broccoli or the, whole grain carbs that you can eat freely whenever? And then on those red and yellow category foods, being able to work with people around exposures, it's trial and error, just like medications are in psychiatry,
Yeah.
right? Like, let's try it and we can see how it works.
I like your perspective so much of that gives individuals a voice in the conversation and in their own treatment. So it really is a patient-centered discussion of you tell me what you're struggling with. Like I'm not there with you, as you're facing these eating decisions. So it really empowers and validates their experiences in a way that also offers hope for tailoring treatment, for nuancing things in a way that ultimately works with their lifestyle and their cultural preferences, all of those things are accounted for in these conversations. And it's something I really appreciate.
Yeah, well, so here's a question related to that, right? Like um in the substance world, oftentimes, when people talk about that reward circuitry and the prefrontal cortex, oftentimes you hear this term, well, their brains are hijacked,
Mm.
right? So, and sometimes there's limited insight, right? So, part of treatment is often building that insight and combating sort of the denial and minimization of it. How does that play out, if at all, with ultra processed food addiction? Like, do you see, are there studies that look at the sorts of classic denial, minimization? And if so, how do you help somebody if their brain is hijacked, to make even like reasonable assessments around what they want to try and what they don't want to try?
Yeah, it's such a great question. And I feel like I see it in both ways. Like there are, maybe some populations or some individuals where the limited insight is a really driving factor. I think a lot of people are really distressed by their eating behavior. They just don't know the extent to which like this group of foods is driving that eating behavior. One of the things I hear so often, that is a key clinical sentiment that like drives my like motivation to keep working in this area is I'm so good at doing everything in other domains of my life. Like, why can't I get this under control? Like, what is it about me? Like, am I giving too much in other domains? It's like this personal flaw that's getting internalized. And so that's like maybe the most common lack of insight that I'm like familiar with in my clinical experiences. And it's really diminishing the role that these foods have in overriding hunger and fullness signals in a way that makes it difficult to, tune into these behavioral practices and follow through with, the best intentions of limiting access to these foods in your house. But whoop, there they are in the break room when you go into the office. And it's like you bring your, prepared healthy meals, but you have access to this. And the role of that environment is so minimized that that's something that I really try to bring out in a validating way. I don't know of like the studies that have like operationalized that. I feel like it's a more of a clinical phenomenon that I'm aware of. But there's really some compelling research qualitatively that has validated it. I'm thinking now just empirically, how would you quantify that in a way that
Right.
could get data out there? But yeah, qualitatively and clinically, we see it a lot.
Awesome. Okay, I see a question about our intake process at SunCloud Health. I think somebody on my team is typing an answer to that for you. I'm happy to talk with you about that. But this question is a great question from Anonymous. As with cigarettes, can you envision anything at the state or federal levels that could deal with this, particularly the public policy pieces, the health inequity pieces, the targeting of minoritized populations?
Yeah, I think there has to be. With tobacco products, public policy initiatives and addressing those systemic influences was foundational for creating society level change. So targeting marketing, obviously we've talked a little bit more about the health inequities, but also the targeted marketing for children, those initiatives that have grown of like the cartoon characters on the boxes, like much of that was pushed from the tobacco industry. It was the same playbook they were applying to advertise cigarettes to use. Obviously, we have exposure with these foods and infants in our society, and it's normative. So, thinking of ways to minimize targeting for the most vulnerable populations is absolutely essential. Taxation has been something that's been proposed and tried and moderately successful. But really thinking about ways to restrict or reformulate these foods to be less harmful, to be less addictive. I'm trying to think of ways to work with the food industry because I feel like they're obviously not going anywhere. So, how can we use this knowledge and understanding to facilitate food reformulation or some of these middle ground efforts that might be most realistic? The other thing I'll say about the kind of parallels with cigarettes is that the Truth campaign was really a turning point for reducing smoking in use. And the whole background of the Truth campaign was like these posters or warning labels of like cigarettes cause lung cancer, and here's a picture of someone with lung cancer, really weren't effective for people. So the Truth campaign took the other angle that was like, these products, you're spending your money on them. The industry has made them to be enticing to you, has targeted you in marketing campaigns, like that exploitative lens of like you are just lining their pocketbooks, sure, at the expense of your own health. But it's really focused more on that angle of the industry manipulation and influence in it all. It was really interesting. I'm thinking of ways to translate some of that initiative to an intervention for ultra processed foods. I'm wondering about the feasibility of that, but I'm working on that right
Yeah.
now.
Well, and labeling too. Like in the UK, they have, their food labels that, alert people to potential harms of ingesting the food product contained in the package. And in Brazil, I think they do
Yeah.
the same.
Brazil,
Cigarettes have the warning label on them,
yes.
right?
And so much of like the health halo claims, like a pack of gummy bears says fat free on it. Like that's a health halo that, like those
Organic.
organic. Yes. And it is difficult to discern. Like that's a really obvious example, but there are so many that are not obvious. So labeling things in a very like yes or no type of way can potentially help kind of wash out some of that noise.
Right. Well, and I read an article recently, an opinion piece in Medscape, calling for really food environment changes at the level of hospitals and treatment centers, right? Like we used to have cigarette vending machines in hospitals.
Right.
We don't have those anymore, right? But we still feed people in hospitals the cheapest, most convenient food to make that we know now there's data that drives things like type 2 diabetes, cardiovascular disease, depression.
Yeah.
We're still doing it.
Yeah.
So I think this is going to be a long change process, but
And it's pretty deep seated. Like the rationale for still doing it is not just cost and convenience, but it's partnerships with the food industry for supplying those foods and scales, large scales to the hospitals and deals that are being made. And that goes back to the Truth campaign of exposing the public to those messages and increasing that understanding. Like even as a scientist in this area, I didn't really uncover the depths of this for several years. And, imagine like I'm immersed in this all the time. It's fascinating to think about how much the public could learn in a way that could be really influential and make people like mad about this. I feel like there's a lot of reasons to get mad about it.
right. Well, and also the not all brains are equally susceptible to addiction, right? We know from the substance use disorder world that early early life adverse experiences, food insecurity would be among those, increases your risk for developing addiction or addictive like behaviors. And those are the people that are, you know, minoritized populations, low SES populations are people who have an increased vulnerability, and yet they're also the people that have the most exposure to ultra processed foods and the fewest options, you
Yeah,
know, to to have access to alternatives to that. So
absolutely.
I think there are some huge public health imperatives um, that are just going to be necessary to start bridging some of the disparities in access and health inequities.
Yeah, absolutely. I mean, in our earlier conversation, I was mentioning that it's, challenging for the critique of, well, what about individuals who are on food stamps or other types of programs? Like, would restrictions reduce their access to food? And I try to think about this in sort of an extreme analogy of, if you were desperate for water and your only source was mostly alcohol or like a light beer is how you were getting most of your water, is the problem taking the beer away, or is it you need access to improved resources to satisfy these basic needs? Like that's the
Right.
injustice that's happening is from a systemic level.
Right. So there's the imperative would be it is a basic human right to that all people in our country have access to a variety of foods, including fresh fruit, fresh vegetables, whole
Yeah,
grains, not
absolutely.
just foods that are going to worsen the inequities we see around hypertension, diabetes, cardiovascular disease.
Absolutely.
Okay. I wanted to ask a question about weight stigma
Hmm.
and diet culture,
Yes.
which are both, I think people living in larger bodies have been harmed a lot by the medical community,
Hmm.
right? And one of the questions that comes up often is, well, how could you possibly treat food addiction and not add to weight stigma? So I
Hmm.
really appreciate that in your presentation, you said this is not about like reducing caloric intake, right? Like, or decreasing a person's, restricting from a overall calories and nourishment in perspective. And just what can you say on that topic when people do bring that question up or that criticism
Yeah.
of this?
From my perspective, I feel like too much of the scientific literature has focused on obesity as a proxy for eating related problems or overeating. And that is so stigmatizing for, a number of reasons. I think I briefly mentioned like there's just so many things that have an influence on body weight, and many of those things don't relate to eating behavior or inactivity. And to think that our food environment relative to like the choices that we can make for physical activity or like nothing could cancel out the role that the food environment is playing in this. And one thing that I think is hopefully validating is by focusing on a presentation that is behaviorally oriented, that people are saying, I'm struggling with this and it's causing significant distress in my life or impairment in my roles. That can happen irrespective of body weight. And it's also validating for their actual experiences of overeating as opposed to using body weight as a proxy to suggest that they might be experiencing, eating related problems. Importantly, if someone does have a higher body weight and they're not saying that they're struggling with their eating or experiencing distress or impairment with their eating, then nothing needs to change. Like that, I think that's also extremely important. Like this presentation relies on distress and impairment that an individual is telling us about that they want help for. And I am personally feeling like that's more validating and patient-centered than just applying this kind of blanket guidance to a group of people who may have, very different perspectives relative to what their body weight, is a proxy for. So I hope that speaks a little bit to
Yep.
yeah.
For sure. No, that's great. And then one last quick question.
Mm.
The MyFast or the YFast, the probably the most widely used measurement tool to measure food addiction and help with diagnosing people. When we know that when people are malnourished, and food restricted, that their scores on that tool are oftentimes elevated. Up to 50% of people with anorexia nervosa will have a positive YFAS. So what can you say? Can you speak a little bit to why that happens, and then what are some alternatives in the way of diagnosing this construct?
Yeah, you're giving me like a layup, but I don't know if you realize it or not. But essentially, so the explanation for this is really thinking about like a question that says, I ate more of these foods than I intended to, tapping into that loss of control. Of course, someone who intended to eat very little or none of these foods is eating more of those foods than they intend to,
Yep.
even if it's a normative amount. So it's essentially a false positive for a self-report measure. And my layup is that I created a or a semi-structured clinical interview based on the SCID, so the diagnostic interview for assessing substance use disorders. It's like the gold standard, and applied that to ultra-processed food addiction. It got published like a few months ago, so that is hopefully going to become a complementary tool the same way semi-structured interviews are for depression to like the Beck Depression Inventory. Still a really important self-report screening measure, but it doesn't provide like the clinical judgment and that final picture of diagnosis. So hopefully that will be
Yes.
a tool. Yeah.
Thank you for publishing that and doing that work. It's been one of the pieces that have been missing from, from this work. So, okay, well, we are at the 12:30 mark. I want to again thank you so much for coming and sharing with us, and just for all of the just your unique perspective and how thoughtful it is and comprehensive it is, and the work that you're doing.
Thank you
Really
so much for
appreciate you.
having me. It's a real
And
pleasure to
Yeah.
be here.
yeah, and just to follow up, thank you. It was amazing. As a follow-up, you'll be receiving an email from us. I have reached out to those who have asked about referrals, so you will be receiving an email from us on that as well. But always feel free to reach out to me. You'll have that information in the slides that we are going to send over to you after the presentation. Thanks,
Thank
everybody.
you.
Have a great
Bye.
Bye,
afternoon.
everyone.